Okay, so good morning, everyone. Think we can start. So we reached number 187. So if a drug has plasma elimination half-life of 4 hours, how much of the drug present in the plasma will be eliminated after 8 hours? So I think I don't know if we're supposed to use okay, over here you don't use the formula, I think, but it's obvious that or anybody with a different explanation, I don't know.
I think so too, Hiral. We always assume first order metabolism if we are not told. So yeah, I think 75%.
Yeah. So the equation is, the formula for half-life is
It will be T half-life will be equals to 0.693 over K.
yes.
Yeah.
So in any question, if you're given now the K, then you would use that formula. But in such a case, it's just obvious.
Please repeat.
When you have if the question is asking for the half-life and you're given the K value, then you use the formula of 0.693 divided by K, you get your half-life. But in such a case, we know that if, for example, over here, the plasma concept, they're telling us that the half-life is 4 hours. So that would be, if it's 4 hours, then it would be 50. Then if it's at 8 hours, then it would be 75. And so if we start for like from 2 hours, yeah, then it would be 25. And then the half-life at 4 hours, which is now the half-life of that drug, it would be 50%. Then if you increase more, if it's more, then like over here, 8 hours, then it would be 75%. So it's exponential, I think. Yeah. So I think everybody agrees with A, or anybody with a different answer. Okay. Then I think we can go to the next question. Which one of the following vitamins is given to newborn babies to prevent hemorrhagic disease of newborn?
Hiral, that question 187, it shouldn't be 100%.
Wouldn't that be, because I was assuming that like if it's less than 4 hours, like for 2 hours it would be 25.
Mm-hmm.
And then at now 4 hours would be 50, and then if you increase more, or like
Then
8 hours.
Be 75.
Sorry?
Yeah, Sophia is right. So at 6 hours, it is 75.
Yeah.
At 8
So
hours,
at
it's
it will
100%.
be because if the half-life is 4 hours, then so at 4 hours 50% of the drug will have been eliminated, Cindy.
Yeah.
So other 2 hours, then 75%, which is 6 hours. So in 8 hours, then it's going to be the drug will be 100% eliminated. I don't know if I'm making sense.
On that, Sophia, this is my thinking. Because we say just from the definition that half-life is time it takes for concentration to fall by half, right?
Yes, but yeah.
And yeah, and here we've been told it's 4 hours. So let's
Mhm.
start at it was 100% at
Yes.
time 0. So
Mhm.
after 4 hours, it will be 50%.
Yes.
Apple, yeah. Then now that means after another 4 hours, the
Mhm.
concentration will have fallen by half. And half of 50 is 25%. So 25% is what will be remaining in the body. Then that means 75% will have left the body. Well, that was our thinking with the Hiral. 100 to 50 takes 4 hours. 50 to 25, it will take another 4 hours.
Yeah, if the half-life was now 2 hours, then 100% would be correct. But you see, it's not, the
Okay.
half-life is 4 hours, so it's every 4 hours, not every 2 hours.
Okay.
How do I clear the screen now?
Pardon, Shina?
How do I clear the screen?
Just
They should be
do
on
Oh.
your left. There should be something drawn a dustbin.
Oh, okay.
Yeah. Then you clear all. Even the rubber works.
Thank you.
Okay, yeah. So the next question. I think I saw somebody write B, vitamin K, or what, that was for another question.
I meant for question 188, vitamin K.
Vitamin K, okay. You can explain to us why vitamin K.
Because newborns' coagulation process is usually not fully formed, so they're given vitamin K to prevent hemorrhage.
Okay. Then vitamin D is used for, like, just generally.
D is used for bone stuff, bone development, such things.
Yeah, so as long as you have the vitamin D, like the active form, which is 125 hydroxycalciferol, I think, then that increases the absorption of calcium through the gut, right?
Yeah.
Okay. Then vitamin B1.
B1, okay, generally for the vitamin Bs, number one would be as coenzymes, cofactors, and also for the nervous system. Generally, vitamin Bs and nervous system. Yeah. So I'd go with that main role being related to, let's say, healthy nerve conduction and such things.
What's the other name for vitamin B1?
B1 is thiamine.
Thiamine. Okay.
Yeah.
Okay, fine. And then I think we're okay with it, unless anybody has somebody has said vitamin B1 helps with nerve pain in people with diabetes. Okay. And B12 again, it's the same with, think, the nervous system.
Could do it just quickly, because time is flying. Just go through what is given to the child at birth, at 6 weeks, 10 weeks, just quickly, and 14 weeks, and 9 months, such things. Those immunization schedule, not looking at the types of vaccines, just the what is given. If anyone knows, they can just unmute so that we can go as quickly as possible.
I know they're given the BCG and polio, but I don't know at what time, like how many months or things like that.
Okay, if there's no response here, we can just move. Hopefully it will get typed on the chat box, but because of time, we can just move.
Fine. The next question. The appearance of crystals in mannitol injection solution indicates that the product was formulated using sterile saline, has settled during transportation, contains impurities and should be discarded, and was exposed to excessive cold. Answers, please.
Okay, it is crystal. It's because the crystals are formed because of the poor storage, and it usually happens in cold temperatures. So I think the answer is D.
Yeah, that makes sense. Anybody with a different answer or any other explanation?
And the storage temperature for mannitol should be 20 to 30 degrees.
Okay. I don't know if we should discuss anything over here, so I think we can move on. So yeah, so the answer to 1989 is D because of the low temperature, crystal formation at low temperatures. 190, sorry.
We can just remind ourselves that it is diuretic and helps to remove excess water.
Yes.
Used for heart, kidney, or liver diseases. Also, if there's a swelling in the brain or around the eyes, you can use mannitol.
Okay. Next question then. A prescription order includes the directions, that one. Which of the following auxiliary labels should be affixed? For the rectal use to be taken with meals. You guys can hear me or I'm breaking? Okay. I think we can send a picture of all these prescription instructions. I think that would be easier. Yeah, so I think the first one, this gut is to put. AU is for ears, so both the ears, and QID is 4 times a day. So yeah, I guess the answer would be B. Yeah, sorry. Gata is to like the drops, how many drops or whatever. Or to, yeah. I think we'll just send a picture of all these instructions on the group so we can move on. Endemic means that a disease, I think we've discussed this before, and a picture was also sent on the group. Yeah, so the picture that was sent on the group, endemic disease is constantly present in a certain population or region. So it can be all over uh, the world, but just certain regions. Then epidemic is when there is sudden increase in cases spreading through a large population, like in a country. And pandemic, we all know it's everywhere. It's across the world, all countries. So yeah, I think over here the the answer would be is habitually present in a human population. Okay. So several studies have found that approximately 85% of cases of lung cancer are due to cigarette smoking. This measure is an example of. Someone is asking, is cancer a pandemic or an epidemic? I think it's a pandemic because it's all around the globe, but I'm not sure. Anybody with a different answer or? So we would, for cancer, we would say it depends on the country, or like how? Okay, then. Okay, we just move to the next question. Yeah, so 192. Answers for 192. We can also see what the others mean.
Relative risk is the probability of getting a disease if you are exposed to that factor.
Sorry, please repeat that.
Relative risk is like the probability of getting a disease. Sorry, so I think this is relative. Because if you smoke, it's a high chance of you. It's a probability that you can get cancer.
Okay. And what would be
Prevalence risk is now the proportion at risk. Sorry. The proportion at a risk population that develops a specific health outcome with a specified amount of time. So it's like a measure of risk. It's a measure. It reflects the number of existing cases of a disease.
I think with incidence, it's more of
Even
sorry.
no, you can just go on.
I couldn't hear you, Shrin.
It's okay, you can finish your statement.
Well, I'm saying that I think, to my understanding, that incidence would be the measure of the new cases of either disease or whatever we measure. But with prevalence, it just doesn't look at the new cases per se, but
Yeah, I agree with Chai. I agree with Chai. Don't know if his internet is breaking. It's mine.
Attributable risk is the difference between the incidence risk rate in exposed and non-exposed groups. So what could be the answer?
The attributable risk is actually the answer. So if you look at the definition, from the definition of an attributable risk, they're saying it is a measure which describes the percentage of cases of a disease that are due to a specific exposure. So I think whatever you gave was actually the how to calculate it. But from its definition, it actually describes the percentage cases of a disease due to a specific exposure. And in this particular case, I think that is what we had, because they're describing the percentage number of lung cancer in association with cigarette smoking.
Hi, Sam, can you repeat the definition, Tena?
He said it means it's the the percentage of disease risk that is associated with the exposure factor. I think that is what he meant.
Yeah,
Okay.
and that makes
But
sense.
let me,
Mhm.
well, in that case, wouldn't that be, I don't know, maybe it's English is serving me, but wouldn't that be like 85% of smokers are at risk of lung cancer?
Yeah.
I've just shared something on the group. You can have a look at it. Basically describes what I was saying.
We can also discuss lung cancer, the types and the treatment modalities. Anybody that can take us through lung cancer?
Hiral, maybe I'll just say what I know about lung cancer. Perhaps someone else can add on the same. So lung cancer, is one of the most common types of cancer. I don't know what number it is, but of course it's one of the most common and the most important, or the causative agent is usually smoking. Like smoking is regarded as one of the most important risk factors for lung cancer. And the other things would be even exposure to environmental carcinogens, like, for example, people who work in polluted environments, stuff like that. About the other risk factors, of course, family history of cancer. I'm assuming, okay, those are the ones I can mention under the risk factors. Then under the types, we have the
Sorry,
Uh-huh.
guys.
Uh-huh.
Just because you're talking about risk factors, I'm
Mhm.
reading that even metabolic enzymes that process carcinogens like efficient phase 2 metabolism. So that means there'll be reduced carcinogen clearance and there'll be an increase in CYP2D1, and that leads to the formation of active carcinogens.
Thank you. Yeah, so smoking, family history, environmental pollutants, and the which can be affected, as she has said, leading to carcinogens are not being cleared as fast or as efficient as they should, while the other type of metabolic dysfunction is that there is a higher rate of formation of the carcinogens. Okay. So for the types, there's a small cell carcinoma and the non-small cell carcinoma. Small cell and non-small cell. The most common is the non-small cell carcinoma. And but now the small cell is the one which is more sensitive to therapy, chemo, and such things. So most common non-small cell, but small cell is the one that is more sensitive to chemo. Okay. Then on the stages, I think that is basic. Stage 1 in the lung, stage 2, it's reached the lymph nodes, stage 3, lymph nodes outside of the lung, stage 4, it's metastasis. So I guess for symptoms, things such as cough and blood tinged sputum, I think those are the two that I can remember well. Coughing is a chronic cough, and then it reaches a point someone is coughing blood that really should probe for assessment for lung cancer. And then now when we go to the management, like any other cancer management will depend on the stage. If the disease is just limited to the lungs, you can do the chemo with or without the radiotherapy. And the chemo is usually a etoposide plus a platinum agent, cisplatin, carboplatin, such a thing. Yeah. And the same applies for, I know the same applies for non-small cell, whereby you have to have a platinum agent, but now for the non-small cell, you can give something like paclitaxel and docetaxel. Yeah. So that's all I can say about lung cancer. Maybe if someone else has something to add on the same, it would be nice.
How can you differentiate between non-small cell and small cell? Or that is now with like histologically or
Yeah. that is with histology. When you do the biopsy, the pathology studies, they'll indicate whether it's a small cell or a non-small cell. Yeah.
Okay. Anything else? Anybody else do? Oh yeah, and then for the extra pulmonary symptoms, like if there's metastasis, then there'll be like, if it's to the bone, then you'll have bone pain, or if there's like, if it's spread to other lymph nodes, then there'll be enlarged lymph nodes, and just those common symptoms.
Then Hiral, perhaps you can if you there was something about non-small cell. I think it was non-small cell, that it's those type of tumors that can also produce a hormone such as ADH. I think there was an association between non-small cell and it producing too much ADH, leading to that syndrome of inappropriate ADH. I remember vaguely. I don't know if you can.
I know there is, but I think, is it ADH or I think it was that one, ADH only. But I'm not too sure. Maybe if somebody else has another. Yeah, someone is saying that it does cause that. Okay, so I'm just trying to understand how it causes this syndrome of whatever. Is it because the lung is also involved in the conversion of some enzymes? Is it from angiotensin to angiotensinogen? Like, I'm just trying to remember what it was, or I'm confusing it with something else.
I think it was related to, or rather not even related. It's whereby the affected cells, the cells themselves are usually the bronchial epithelial cells. And we know the most common type of non-small cell carcinoma is adenocarcinoma. And we know with adeno, it means there's some glandular tissue involved. Now, with the mutation, somehow the mutation leads to promotes the production of ADH, not even promotes, actually synthesizes ADH. But what I'll check and send the explanation on the group. Yeah, I'll look for it on the, I think on one of our PowerPoints it was stated.
Okay, and also one more thing, the small cell carcinomas are actually like, they're sensitive to chemo compared to non-small cell carcinoma. And also the staging is different for both. For small cell is you classify, like, the staging is based on like limited stage or extensive stage, while non-small cell carcinoma is now stage 1 to stage 4, like the way Gaius explained. Yeah, I think that's it for lung cancer. Anybody else that wants to add? Okay, then. So the next.
Oh, Hiral, I don't know if this was mentioned before, but for small cell lung cancer, it's more aggressive and it has more tendency to metastasize. And the non-small cell cancer is like it's lower in terms of metastasis and progression.
Okay. Thank you for that. So next question, a relative risk can be used when?
I think D makes the most sense in terms of relative risk, because that's how we describe relative risk. Like you're relatively at risk, but you may not get sick, but you have some risk. I get, but my thoughts. I'm not a statistician like Kushal.
Okay, then should we move on? Okay. If an association is found between the incidence of a disease and a certain genetically determined characteristic. Yeah, even I think for this question, A makes the most sense. For 193, what do the other MCQs define? I don't think they're like a definition of something, but I'm not sure. I'm not too sure if anybody else has a.
Me, I'd go with C. That genetic factors are implicated, at least for some cases of the disease.
But when we're talking if there's a relation between the incidence of the disease, like you see, the question is asking if there's an association between the incidence of a disease and a certain genetically determined characteristic, or it can be C because it's not always genetics.
Yeah, those are my thoughts.
Okay,
like we can't say it's totally genetic, like schizophrenia. There's some association with genetics, but some cases there's no genetic component, but people still get schizo. So hence my thoughts on say genetics does play some role in the cause of the disease, but we can't say it's the that the disease is genetic in origin.
Okay, that makes sense. And I think okay, fine.
Then the other thing.
I have a question. What is the answer to question 1 and 3?
Sorry, the answer to which one?
I think it's disappeared. We can just move. The document will be shared. You can type the question you're referring to on the chat box.
Okay. So next question. For 193, we went for D. Or you have a different answer?
What about A? Because what I know concerning the relative risk is the ratio of the incidence risk among an exposed group over the incidence risk among an unexposed group.
So is that the same as prevalence then? Because that's what A is saying. I think we can just put a star on that question. Which one of the following is not a possible outcome measure that could be used as an indicator for the benefit of screening programs? everyone agrees with 195 and 196, then we can move on. Because I think they're correct. Why is 195, why is it not C?
I think it's a benefit because if you can notice that there are less incidences in a population screened, that means that the disease is decreasing or something like that, or your drug which you are giving is being effective, if that makes sense. D, because it's not an outcome to measure. I don't know in what reduction of complications in population or what. I don't know.
I think, okay, I also don't understand how T makes more sense. Because let's say like for cervical cancer screening, it may if it's discovered earlier or something like that, it will help you mitigate it. Like if you discover it earlier, it will reduce the chances of complications later because you'll be able to deal with it early enough. So I don't understand how reduction of complications makes more sense.
Then what would have been the answer?
To me, I think C makes more sense. This is why. If you're screening, it doesn't reduce the incidence of it doesn't reduce the condition or whatever, but it will help in future, like to deal with it, like how you're going to. That is my view, though.
Okay, I also have another, like if you're saying C, like you see there's reduction of incidence in the population. Like if you keep on screening it, you know that there are some factors that can like these risk factors. So you know that you're in that high risk. So you stop, for example, lung cancer, the risk factor is smoking. I don't know if that makes sense.
Yeah, it
Is
does.
smoking, then you know you're at a higher risk, then you tell that patient or whoever is being screened that you have to reduce or you stop smoking. So that would reduce the incidence in the population, right?
Yeah.
That's how I thought of, yeah.
But
So
on that, Hiral,
yeah.
choice D, reduction of complications. Let's say we go to the same place, screen for that lung cancer as you described, and we find a few patients here with lung cancer, and we give them an early treatment. Wouldn't that reduce complications wouldn't that reduce complications? Because, for example, if we can say stage 4 lung cancer, we've seen syndrome of inappropriate ADH as a complication of lung cancer, but we screened, we found it early, we treated it early. Wouldn't we be reducing complications?
But aren't you screening for before you've got the disease? Before you've got the disease, you're not scanning, you're not doing the screening. Like the screening programs are, if you're at a higher risk or you're not doing like the screening programs to diagnose. You're doing these programs to see if you're at a higher risk or not, or if you can get it in the future. Like you don't do screening. You don't do screening to diagnose.
But when we say breast cancer screening and the ladies, they come and you test, you palpate for any lumps, and you actually found a lump in the screening stage, and due to that screening, you take them for the mammography, you get the cancer early. Like in screening, and you find a symptom, for example, in lung cancer, you find coughing with blood, and you found that at screening, and it leads to a diagnosis, hence leading to early treatment and lesser complications. Isn't that an advantage or a benefit that we've gotten from screening? Yeah, like Mbovi is saying that you can't separate screening and diagnosis, because you can screen someone, they are safe, but then you screen the second person and you find a lump, and now you have to do further assessment.
Okay, fine. I understand that it's one of the same things, but the main purpose of screening is what?
I think it's early detection.
I thought so too. Early detection and prevention through education.
Okay, so then the answer would be?
I'm saying there are people who are even for choice A as being the answer. Reduction of case fatality in screened individuals. Now we have A, C, and D. Maybe B
Hello?
is the answer now.
Hello. I think the issue you are saying reduction of case fatalities in screened individuals. Hiyo mnaelewaje? Kwa sababu like the moment you screen people, sema kama saizi mtu alikuwa cancer stage 1, si ndio? Are you not reducing the case fatalities when you do the diagnosis, when you do the early diagnosis? So I think A is right. Reduction of complications. So A and D are right?
Okay,
reduction of the complications and the reduction of the case fatalities in screened individuals, okay? Then when you go to the reduction of mortality in the population screened, ukisha screen mapema and you get treatment mapema, you are reducing the mortality, sawa? The reduction of incidence in the population screened is wrong. Kwa sababu saizi, according to the definition of incidence, it is the rate of new cases of events over a specified period of the population. Sindio? Then, so the reduction of kama saizi, there are some people who don't have cancer, okay? But with the time, wanapatikana wakiwa nayo, sawa? So the time unasema the reduction of incidence in the population screen, that is wrong.
Yeah, me I'm with Mbuvi on this. Because actually, if the way even he's explained, all the answers are related except incidence. When you say mortality, case fatality, complications, you can say all of those are related. Death can be a complication of cancer. So how can it be someone we are saying mortality is there, but complication is not there? So I'm still with choice C. Incidence, we can screen you for breast cancer today, no lumps, no nothing. But then 2 years we come back and you have it. Like the screening didn't do anything in terms of the new cases.
So since the answer is asking not a benefit or screening, so I think the answer is C.
Yeah, I'm also for choice C.
Makes sense now. Okay. So should we go to
Barasa has unmuted. I don't know if she has or he had, I don't know. I don't know if they have a they want to comment something on that. Barasa Makari. Ama we can move on.
yeah.
Yes.
Guys, so Janet can take over now, please.
Yes,
I think Janet can take over.
Contribute. When you talk about
Can you get Barasa? Oh.
Now we can hear you, Barasa.
Okay. No, back to the question on screening. I would go for choice D, that is reduction of complications, because when you look at the definition of screening and the whole point of screening, it's all about early detection of disease in patients with no or in a group that has no symptoms. So you're looking for early detection. And when you go to reduction of, when you go to choice D, that is reduction of complications, at the stage of screening, you really do not have any symptoms, and it's like you're not really affected by the disease per se. So for reduction of complications, I think that will be about diagnostic procedures. During diagnosis is when someone has already presented with the symptoms and now you want to start treating them. But at screening, there are no symptoms, and so they are not really affected by the complications. So I'll go with choice D. That is reduction of complications. That is not a possible outcome of screening.
But on that note, how do you eliminate choice C? What's your reasoning behind choice C being a possible outcome?
Reduction of incidence in the population. Yeah, when people do not have the symptoms, they can be exposed to the risk. So during screening, you advise people to really minimize on exposure to the risk. And with that, you will reduce the incidence of new cases in the population.
Okay. Can I give an addition?
Yes, I'm good.
Yeah. Okay, so we usually have levels of disease prevention. We have the primordial, we have the primary, secondary, and then the tertiary. So for primordial, usually ni vitu kama campaigns, telling people to drink water, to avoid salt, basically just to, okay, give me a minute.
Excuse.
Yeah, go ahead.
I think probably people don't understand the complication, because like complications is a problem or a difficulty that makes a situation harder to deal with. Okay, tuseme kama saizi you have diagnosed someone with cancer type 1, okay, and you treat it. Are you not avoiding the complications of the of the cancer if it is not screened?
Yeah, those are my thoughts, because if we say
no, but when you go to stages of a disease, I think we had the asymptomatic, then you progress to the symptomatic stage. After that is when you have the complications. Now, I can't remember the exact sequence of prognosis of a disease, but complications come at a later stage. That's why you have like rehabilitation, or someone can be handicapped. So complications come at a later stage when you already have the disease. It has already progressed from the asymptomatic to the symptomatic stage.
But now, Barasa, what Mbuvi and I are asking, let's go even to a simpler disease, hypertension. You're just going to check people's pressure, and you find someone's pressure is elevated, and you start them on an antihypertensive mapema, right? That means CKD, which is a complication of hypertension, will not happen because you found the hypertension early and you managed it early. Hence, the CKD will not happen. That is what we are thinking. I'm not saying we are correct. I'm saying that those are our thoughts. So debunk that, say how that is wrong.
Hello.
Yeah, Hannes, go on.
Hans. Yeah, so what I'm saying, Canu's point, there are like 4 levels of prevention in disease in epidemiology, and they start with primordial, then there's primary, secondary, then tertiary. Screening falls in the primary prevention of disease. And the reason for primary prevention in Akwanga, intervening before health effects occur. Now, the reason we are saying you are going to reduce incidents, when we are screening, we are not screening is not diagnostic most of the time. Screening is just finding people maybe who are at a risk of developing hypertension. For example, you're talking about hypertension, people who are at a risk of developing hypertension, maybe because of, if we find you we are going to screen you and then we find you at a prehypertensive state, we can advise you on what to do. Then you're going to reduce the incidence of hypertension. The reduction of complication, that usually is a secondary prevention of disease, where what we are doing is we are screening to identify the disease at the earliest. Now, whatever you're talking about finding hypertension at the earliest and giving it, giving the correct, rather the necessary interventions through medications and advice. At that level, we call, that action is called secondary prevention. Tertiary becomes managing the disease post-diagnosis. So maybe unapata mtu ako na advanced hypertension, maybe ako huko stage 3. Stage 3 hypertensive, now we start doing things like, we are trying to look for further complications that can come out of that. So the disease has been established, but we are trying to slow the progress of that disease. So screening does not reduce complications.
Okay, let me ask you, what was it, Hannes? So, so screening does not reduce complications, but it reduces mortality. That is the logic. Because this is my take. All those answers are probably correct. Like we're looking for the best answer in this case because everybody's case makes sense. No, if you were to look for the best out of the 4, if you go with reduction of complications, what about the mortality and the fatality? Because those sounds like also complications.
Mortality and fatality, okay, so case fatality, for example, is just, case fatality refers to, I think, deaths or other fatalities within a diagnosed population. The reason we are saying this is these two can be used as indicators is, I don't know how to say this, but reduction of complications is not a good indicator of screening, or rather the efficacy of screening. Mortality, it is a good indicator because maybe to say people have been dying from cancer in a place, and then we start screening more and more and more. And the reason we're doing screening in to prevent symptoms from developing. Then as an indicator of screening, of the effectiveness of the screening, yes, mortality is a good measure of it. Reduction of complications, I don't know, man.
That, how can we draw a clear line between mortality, death, and complication? Sometimes even death is a complication, and then we are saying
And
it can
sometimes,
be mortality.
yeah. And sometimes it's the complications that will lead to the death, not even the condition itself. It's the complications that will lead to the fatality. So,
I don't know, man. I don't know, but I would go with C, bad though.
Oh, you're going with choice?
D, reduction of complication. That is not.
I think on that, we cannot, all choices there can be justified with an explanation. And anyway, mistake, you can decide what we do next.
they do picky ponky. It's okay. The goal is not 100%. But we move on. So accessible hypothesis, any argument, any dispute? It specifies how two or more variables are related. Basi tuendelee 197. Why is sample size population? Why is sample size important in clinical trials? Large sample size. Lots answers. Okay, C makes sense.
I think C is fine.
C is fine. Any disputes, additions? So we continue. A large amount of data can be summarized using inferential statistics, descriptive statistics, graphs, population parameters. A large amount of data can be summarized using, I don't know what inferential statistics is, but the graphs also make sense in this case. Yeah. So I think we're going to go into details how data can be presented. Anyway, moving on.
Sorry, what did you say the answer is?
C. For both of them.
D.
How?
You are saying D.
C. C. Sure enough. C. C for cat.
Okay, continue.
Even when intuitive going for cat. Yeah. Okay. So the scientific communication method that reaches the widest audience and provides a permanent record is presentation at national conference, discussion at scientific meetings, publication in scientific journals, interview with the mass media. Somebody is saying B for 198. Have we already 198? Should I go back to 198? Descriptive statistics. Huh. Okay. What's this, like, what is descriptive statistics and what is inferential statistics?
I think descriptive statistics is like writing in words. I'm not sure.
Okay.
But I feel if it's a large amount of data, that would become too wordy.
Yeah, because the keyword is summarized.
Yeah, I think so too. Yeah. Descriptive for a large amount, you write everything, but
Yeah, I think the keyword here is summarizing it.
yeah. This is where you will take a sample.
Descriptive statistics state facts and proven outcomes from a population. Inferential statistics analyze samplings to make predictions about larger population.
So they are all analyzing data. Wait,
I think it's predictions, like what will happen.
Okay.
Yeah.
And you can see predictions in graphs. If you can extrapolate. Me, I'm still sticking with graphs for that answer, for that question. Mwenye alikuwa amesema B, do you have something to say?
Let me just read something on descriptive statistics.
Okay.
Just I think 3 statements that may help. It says here that descriptive statistics describes the characteristics of a data set. It is a
Okay.
simple technique to describe, show, and summarize data in a meaningful way. You simply choose a group you're interested in, record data about the group, and then use summary statistics and graphs to describe the group properties. So it's still based on that explanation here, it's still coming back to graphs. Because I think graphs is the easiest thing, but
I feel like some of these questions is choosing the best answer. Like even the descriptive statistics can be an answer, but it's more, which one are you more likely to?
Which one would best
So
summarize?
what I'm finding is graphs is part of descriptive statistics.
Okay.
Like unaona venye unakwanga na umbrella. So descriptive statistics iko huko juu, alafu graphs is one of the ways of displaying the data. But,
Yeah,
but
so
in case you guys want to know what inferential statistics is, it's where you use some data to make a prediction about, like it's a way of making prediction. That's inferential like you're inferring from a set, then you're making a prediction from it.
Okay. Okay. So
yeah, also other measures. The other measures include like bar charts, histograms, standard deviation, mean, median. So all that, even with the graph, is under descriptive statistics, as he has mentioned.
Okay. So we switch to descriptive statistics. Rina. Yeah, change to boy. 198.
I changed to
B. Bananas.
Wait, why are we changing to B? I don't get it.
So they said all those things such as like the pictures, like pie charts, graphs, all those, they're all part of descriptive statistics. So descriptive statistics is like a whole umbrella of ways to summarize data.
But then, okay, I'm using an example of like, there's a number we did a while back on this same paper where they asked us for like the science which is like, which works with like knowing the amount of drug, the dosage of drug. And then they gave us, one of the answers was pharmacology and the other was posology. So we chose posology, yet posology was a subclass, was under pharmacology, like a sub branch of it. And then we still went with posology because it was specifically to that answer. So wouldn't it like the same thing here? Like, yes, descriptive has all these other things, but specifically what we want under all those other things is the graphs.
Graph.
Is it? Or am I overthinking it?
The more you know, the harder it gets to answer.
Yeah, the more you know. I think with board exam we should stop the content with what we have. The more we know.
The more you know, the more you overthink. So, yeah.
Because I'm having Chai is inboxing me on the WhatsApp and on the Zoom chat, and he's saying he thinks it's population parameters. So you see.
Okay.
You wonder how some people can be helped.
Yeah. Chai. That's a special case.
Hey, go take some chai.
Ahead of you.
Moving on swiftly. The scientific communication method that reaches the widest audience and provides a permanent record is, me, I'm going with my primary school knowledge here and going with mass media. Leaves a permanent, provides a permanent record. But
you know that one permanent record.
Permanent,
yes,
yeah, the permanent.
Mass media will reach everyone, but permanent record is
I think some media are always permanent once it hits the net.
I think an interview with mass media can also be published in a newspaper, so I think it's okay.
The mass media in different forms.
Yeah.
Publication, scientific journal that is only reaching a specific audience. Scientific meetings, still a specific audience. Presentation at national conference.
That's for stakeholders. So I think with the mass media works.
Yeah, I think mass media, yes.
Okay.
Yeah.
The purpose of a double, why not C? Publication in scientific journals. I mean,
I
I'm
think
going
for that, we can just ask
That one is
Chambi,
for
when is the
professionals.
last time she read a scientific journal?
Yes.
And when is the last time you watched TV?
News.
I think
And mass media are different. Yeah, mass media reaches a broader audience. For scientific journals, it's a specific audience. It's
Yeah,
like a
it's usually for professionals because it goes into detail.
But mass media, is it permanent? Yeah, it's Jamie, have you seen people being fired because of things that were interviewed like years ago or stuff like that? Like some of these things do tend to be permanent. Newspaper is also a mass media form of communication, as Patrick said. It is permanent.
And you can save it on YouTube. So
yeah, and even on TV, they do record these things. They are permanent and public records.
Yep.
The purpose of a double-blind study is?
Guys, so because the scientific methods usually require data to prove what you're trying to say, you guys have data to prove what to substantiate your answer. We're dealing with a question of scientific methods.
Communication. What do you mean?
Sam, pardon?
Yeah.
It's recommended that you use data to substantiate your answer. So do you guys have any scientific data to substantiate that the answer is D? Since the scientific method question.
Okay, scientific communication which is the weirdest.
Janet.
Only messing with it, but okay.
Yes. Continue.
How about C, publication in scientific? How about publication in scientific journals? That one is also a permanent record.
That's true.
It's permanent, but do you think everyone will get access to the journal? Because the point is the widest audience and still permanent.
What about the illiterate people
And then
cannot
the
read?
publication. How sure many people won't read usually don't read the journals?
I think hivi tuache kufikiria sana bana. Let's stop thinking too much. Like the truth is, I'm not sure my mom or my dad would buy maybe a journal from like maybe a PSK, for example, but I'm sure they're going to watch news today, and that news can be found.
Even how COVID was happening. They used to communicate mainly using mass media. Not there were journals, but mass media you can still get verifiable depending on who you're listening to. Also, you can still be able to reach a wider audience using mass media. This is a scientific communication method.
I think we are thinking too much. Yeah. Interview with the mass media is the most. It will reach the widest. It will reach the widest kind of audience.
Yeah, because I mean, okay, here there are three keywords, and I think that's what people are arguing. There's scientific communication part, there's a wide audience, and there's a permanent record part. So we're looking for one that hits the three key points, not just two key points. That much wrong.
You've seen interviews about cancer, for example. Like I'm sure today in one of the stations, there's going to be a doctor somewhere talking about cancer. They're going to be asked about treatment. They're going to be asked about prevention, about causes and things like that. I think when they're presenting things like this, that's scientific anyway. They're presenting scientific facts. I think we are overthinking the obvious. We're just, it's D, man.
ChatGPT amekataa, amesema ni fake.
Application. Aya, wacha wasome journals basi. Hii pekee amsomi by the way.
The explanation is on the group.
Which group?
So types of scientific communication from hapa naona ni academic journals, textbooks, newspapers, infographics, and nini, and interviews. So I think we can draw a conclusion from that.
Oh, interviews and newspapers are forms of scientific communication.
So I think mass media is the easiest one.
Je, mtaambia PPB weke part ya explaining your answer? 'Cause so if people still want, after that explanation, do you still defend public publication? T-Bag,
Yeah.
you still defend publication in scientific journals?
Because they're saying the mass media might not always, even if it might reach a greater audience, it might not meet the criteria for it to be used as credible evidence.
Okay. No, me and my two brain cells would have anyway. So what do you guys think? What do you guys think? To overthink, to see overthink? Because team they all presentation of national conference publication in scientific journals does make sense, and also to kiangalia in a different perspective about an audience, it does also reach a wide audience, because you can still read a journal from somebody from Russia or it's from Italy or from wherever. It still does reach a wide audience. You really hamsel me. Nice.
Yeah, bye.
So based on the internet or better sources other than Patrick, is basically publications in scientific journals. That's what you're saying. I'ma just highlight both. You too. You can get example, but doesn't have to keep on that one. Okay. The purpose of double-blind study is to achieve comparability of treated and untreated subjects, reduce the effects of sampling variation, avoid observer and subject bias, avoid observer bias and sampling variation. Let's go. What do you guys think?
Personally, I think
Personally, you think?
is the correct answer because
Yes.
basically you this is the correct answer because basically the observer and the subject don't know the what drug is being tested on them, for example. So because of that, neither of them is going to be biased because neither of them knows any neither of them knows the person.
So the patients from getting the placebo effects. Okay, there we go. So are we done? End of text. I guess I want to go do the board exam now. Is there another paper?
Lunchtime, Janet, lunchtime.
Oh, well, we just woke up. Okay. Breakfast it is.
So I was just suggesting that 1 hour break between
Okay.
7 to 8 is very little. How about we do 4 to 6?
4 to 6. Me, I'm done for whichever.
Then 8 to 10.
Yeah. Yeah, 4 to 6 is better.
4 to 6, then 8 to 10.
Yes. That's better.
I agree better.
Okay.
Watu wa lunch waende watu wainame. Yo.